All right, welcome everybody to Cardiovascular Medicine Grand Rounds. Just a quick reminder, starting this academic year, if you want to claim your CME, you need to use the Cloud CME app. And it's a little bit different how we were doing it before, but just remember to download that app in order to claim your CME credits. It is my pleasure to introduce today's speaker, Dr. Jasmine Luzum, who received her PharmD summa cum laude from the University of Pittsburgh in 2008. And then she received a PhD focused on cardiovascular pharmacogenetics from the University of North Carolina in Chapel Hill in 2013. Then she completed a postdoctoral fellowship in clinical pharmacology and pharmacogenetics from the Ohio State University College of Medicine in 2016, after which we were lucky enough that she joined the University of Michigan College of Pharmacy as a faculty. Dr. Luzum has been the principal investigator of her clinical and translational research laboratory at the University of Michigan. The overall goal of her lab is to improve cardiovascular medication outcomes and disparities. Her lab uses a variety of research approaches with a focus on precision medicine and pharmacogenetics. She has over 80 publications. Her research has been funded by multiple organizations, including the NIH and the AHA. She has published in major cardiovascular journals and presented at major conferences. She will be talking today about recent advancements and clinical practice guidelines for the use of pharmacogenetics in cardiology.
Thank you for the introduction. Can you hear the microphone in the back? Thanks for the opportunity to talk to you today about recent advancements and clinical practice guidelines for the use of pharmacogenetics in cardiology. So here are my disclosures. I am an author for the Clinical Pharmacogenetics Implementation Consortium, or CPIC, which I'll talk more about later. I'm also an author of scientific statements for the American Heart Association. So here's the outline of what I'll cover today. I'll very briefly cover some background on what is pharmacogenetics. I'll give you a really high-level summary of what are the current clinical practice guidelines for pharmacogenetics for some of our most commonly used cardiovascular drugs. So I'm not going to stand here and read clinical practice guidelines to you. That would be pretty boring. So I'll just give you a really high-level summary for beta blockers, clopidogrel, and statins. And then I'll talk about some of the major recent changes that are really pushing the use of pharmacogenetics in clinical practice that have happened in the past couple of years. So let's start with some background on what is pharmacogenetics. So the terms pharmacogenetics, pharmacogenomics, or PGX, they're used interchangeably. They all basically mean it's a field of research and clinical practice that assesses how patients' genetics influence their response to drugs. So we know there's many things that affect how our patients respond to their medications and thus influence how we prescribe medications. So there's several biological factors like the patient's age, sex, kidney function, liver function, drug-drug interactions. There's also several environmental or social factors that we take into account. For example, economic stability. Can my patient afford this medication that I'd like to prescribe for them? Or does my patient's insurance cover the medication I'd like to prescribe for them? So there's all this hype recently about this new field of precision medicine, precision health. I don't think precision medicine is new. I think we already practice precision medicine. It's just that genetics is a new biological factor that we need to take into account when selecting the optimal medication regimen for our patients. So that's all the background I'm going to cover on what is pharmacogenetics, because I'll give you some examples of how genetics can affect our patients' responses to their cardiovascular medications. But first, I'll give you just a high-level overview of what are the current clinical practice guidelines for pharmacogenetics for cardiovascular drugs. So we used to not have any clinical practice guidelines, and now we get pharmacogenetic information and recommendations from 3 different organizations, mainly in the United States. So there's CPIC, or the Clinical Pharmacogenetics Implementation Consortium. The FDA also has 2 resources. So I've cited the links to all these resources at the bottom of the slide if you'd like to access them. So the FDA publishes a table of pharmacogenomic biomarkers in drug labeling, and another table of pharmacogenetic associations. And probably what you're most familiar with is the American Heart Association or American College of Cardiology. So the AHA, we've actually published several scientific statements that include pharmacogenetic information, and there's a little bit of pharmacogenetic information in some AHA guidelines. So now we're in the situation where we have pharmacogenetic information coming from multiple different sources. So which one should we follow? I mean, mostly the information is consistent from the different organizations, but the health systems that are implementing pharmacogenetics, they're prioritizing and following the CPIC guidelines. So let me explain to you why. So CPIC guidelines are the best resource for pharmacogenetic clinical recommendations. So I've compared the many different characteristics for these different resources. So CPIC checks most of these boxes. So CPIC is the world's largest group of pharmacogenetic experts. CPIC is also a registered service of the US Department of Health and Human Services. And Medicare recently determined that Medicare will cover pharmacogenetic tests if there's a CPIC guideline for them. So CPIC guidelines are covered by Medicare. CPIC also does systematic, transparent evidence review. CPIC is the only organization that publishes clinical decision support when they publish guidelines. So health systems can use that clinical decision support language when implementing pharmacogenetic tests. CPIC is also the only organization that specifies which genetic variants the recommendations apply to, which is critical. The only thing that CPIC doesn't do is recommend whether or not to order a pharmacogenetic test for your patient. CPIC only makes recommendations of, this is how you could modify the patient's medication selection or dosing if you already know their genotype. So for these reasons, most health systems that are implementing pharmacogenetic testing, they're following CPIC guidelines, and that's why I'm going to focus on summarizing the CPIC recommendations for you in this presentation today. But I do have for your information some recent AHA scientific statements on pharmacogenetics that we've published. So our statement on Clopidogrel and CYP2C19 was published in Circulation earlier this year. We also recently published a statement on polygenic risk scores. So the pharmacogenetic interactions I'm going to cover today mostly refer to single gene effects, but there's actually polygenic scores that can also help predict drug response, and we covered that in this AHA statement. And we also just recently submitted our response to reviewers for an AHA statement on direct-to-consumer genetic testing. So hopefully that will be published soon. So here's the AHA citations if you're interested, but I'll mostly summarize CPIC recommendations for you. So let's start with our first example, which is beta blockers. So you may be thinking, we use pharmacogenetics in cancer, right? Obviously, genetics can have an effect on how cancer patients are responding to chemotherapy, but how can genetics affect how our patients are responding to cardiovascular medications? So I'm going to give you just really brief background explaining these effects. And the example I'm going to use for beta blockers is metoprolol, because we have the strongest evidence for genetic effects on metoprolol. So metoprolol is the #6 most prescribed drug in our country, prescribed for a variety of cardiovascular and non-cardiovascular indications. Its primary pharmacologic effect is to inhibit beta-1 adrenergic receptors in the heart to decrease heart rate. So how does metoprolol exit the body? How does the body metabolize and excrete metoprolol? It's primarily metabolized by an enzyme in our liver called CYP2D6. So unfortunately, some of us in this room and even some of our patients have DNA that codes for a broken CYP2D6 enzyme. It doesn't work. So as many as 7% of our patients have a genetic variant that encodes non-functional CYP2D6. So these patients are not metabolizing metoprolol. So even with low doses of metoprolol, they have very high blood levels of metoprolol, which results in a larger reduction in heart rate even on low doses. This has been shown in multiple studies. I've cited just 3 examples here for you. So this has led to our clinical practice guideline. The CPIC guideline was published just a few months ago. So us in this room on our patients, we have genetically determined CYP2D6 metabolism. Some of us have ultra rapid CYP2D6 enzymes. Some of us have, quote, normal. Some of us have intermediate. So your CYP2D6 enzyme works half as well as someone with normal CYP2D6 function. And then there's a minority of people who have poor CYP2D6 function. They have those genetic variants that encode non-functional CYP2D6. So for most patients, if they have ultra-rapid, normal, or intermediate CYP2D6 function, that would just be standard beta blocker selection and dosing. But the minority of patients who have poor CYP2D6 function, if we're going to use metoprolol, it's recommended to initiate it at the lowest possible starting dose and more carefully monitor for bradycardia and at any dose increases. So these genetic variants in CYP2D6, they really just had the strongest effects on metoprolol and not other beta blockers. So we didn't make recommendations for other beta blockers than metoprolol. And the evidence was also insufficient for genetic variants that have been studied in this list of other genes. So you might be wondering, like, why am I showing you where there's no recommendations? I just want to know where I should be making changes in my patients. When we published this guideline, we actually thought it was very important to tell clinicians where there's actually insufficient evidence for any genetic effects. So we evaluated hundreds of studies, multiple different authors evaluating multiple studies. And we came to the consensus that that quality and the quantity of evidence was just not strong enough. And this is important for clinicians and patients to be aware of because there's all these new genetic testing companies that are opening, and they're trying to sell genetic tests to our patients and providers saying, this genetic test will predict how you respond to this drug. So we actually thought it was important in the guidelines to say, you know, actually the evidence is quite weak for that. And so you really shouldn't change how you're prescribing this medication. So let's pause for a review question. Patients that have genetically determined poor CYP2D6 function have increased risk of bradycardia with which of the following beta blockers? Is it A, atenolol, B, bisoprolol, C, carvedilol, D, metoprolol, or E, all of the above? So in the room, let's do this the old-fashioned way with hand raising, and then if you're on the Zoom, you can respond in the chat if you'd like. So who thinks it's A, B, C, D, or E? And the correct answer is D. So thank you for paying attention. All right, so that's the current recommendations for beta blockers, really just metoprolol. So what are the current clinical recommendations for pharmacogenetics for clopidogrel? So some background, how can genetic variants affect patients' response to clopidogrel? So you know clopidogrel, it's an antiplatelet drug, it's generic for Plavix. What's kind of unique about clopidogrel is it's a prodrug. So this means that the chemical in the tablet that the patient is taking is not, it's inactive. It can't actually inhibit platelets. A prodrug needs to be activated for it to actually do its job. So clopidogrel needs to be activated in order to inhibit platelets. So how is clopidogrel activated? It's primarily activated by an enzyme in our liver called CYP2C19. So a lot of us in this room, a lot of our patients have DNA that encodes for a broken CYP2C19. So as many as 30% of patients have a genetic variant that causes decreased function of CYP2C19, and a smaller minority of patients will have two genetic variants, and that causes complete loss of function of the CYP2C19 enzyme. So patients with these genetic variants, they're not activating clopidogrel, so they're not inhibiting these platelets, even if they are taking clopidogrel. And so this has been shown in multiple studies to increase patients' risk of heart attacks or stroke, even if they're taking clopidogrel. So here's what the CPIC guideline recommends for patients depending on their genetically determined CYP2C19 metabolism. So patients who have ultra rapid or normal CYP2C19, genetically determined CYP2C19 function, there's standard clopidogrel selection and dosing. So they're able to activate clopidogrel. But the patients who have genetically determined intermediate or poor CYP2C19 function, it's recommended to avoid clopidogrel if possible, use an alternative antiplatelet agent depending on the indication. So this could be prasugrel or ticagrelor, for example. So these genetic variants in CYP2C19, they don't really affect the other P2Y12 inhibitors. So there's no recommendations for other P2Y12 inhibitors. And also the evidence was insufficient for genetic variants in all these other genes that have been previously studied as well. So here's my next review question. Clopidogrel should be substituted with an alternative antiplatelet medication in which of the following patients? A, CYP2C19 ultra-rapid metabolizers, B, CYP2C19 intermediate metabolizers, C, CYP2C19 poor metabolizers, or is it A and B and C? So who thinks A? Raise hands again. B, C, D, or E? All right, most of you picked E, it's correct. So the correct answer is B and C. Patients who have genetically determined intermediate or poor CYP2C19 metabolism aren't really activating clopidogrel. All right, so here's the last example. I'll summarize some of the recent clinical recommendations for, and that's statins. So we know statins are cholesterol-lowering medications. They're the most commonly prescribed medications in the United States. Their main pharmacologic effect is to inhibit HMG-CoA in the liver to decrease LDL cholesterol synthesis. The liver is also the site where most statins are metabolized and excreted from the body. So how do statins get into the liver? Some statins get into the liver by an enzyme called SLC01B1. And like the other enzymes we've covered, some patients have genetic variants that encode non-functional SLC01B1. So up to 19% of patients have a genetic variant that either causes decreased or poor SLC01B1 function. So if patients aren't, if the statin's not getting into the liver, that means you're having higher blood levels of statins, which means higher exposure to patient's skeletal muscle. So multiple studies have now shown that patients carrying these genetic variants in SLC01B1, they have significantly increased risk of statin-associated muscle symptoms, or SAMs. So I'm fully aware, like most of SAMs is explained by nocebo effect and not an actual physiological myopathy. But the pharmacogenetic effect of these genetic variants depends on the statin. So we see strongest effects on simvastatin, pitavastatin, and atorvastatin, really little to negligible effects on rosuvastatin and fluvastatin. So you might be thinking, well, why don't we just treat all our patients with either rosuvastatin or fluvastatin? Then we don't need to worry about genotyping for SLC01B1. Well, rosuvastatin and fluvastatin, they're transported and metabolized by different enzymes. So rosuvastatin is not transported by SLC01B1. It's transported into the liver by an enzyme called ABCG2. Approximately 9% of patients with East Asian ancestry have genetic variants that decrease ABCG2 function. So I cited 3 examples of multiple studies that have shown patients who carry these ABCG2 genetic variants have much higher blood levels of rosuvastatin than patients without these genetic variants. And a similar story for fluvastatin. So fluvastatin isn't transported by those enzymes. It is metabolized by CYP2C9. Approximately 26% of patients have genetic variants that decrease CYP2C9 function. And I cited 3 examples of studies that have shown patients who have genetic variants in CYP2C9 have much higher blood levels of fluvastatin, which may translate into increased risk of SAMs, or statin-associated muscle symptoms. So with statins, it's much more complex. We have gene variants in multiple different genes affecting multiple different statins. So I'm sure you're aware the AHA cholesterol management guideline recommends statin therapy by 3 intensities, high, moderate, and low. So what we did in the CPIC guideline was subcategorize the existing AHA recommendations by what is the SAMs risk according to the genetic profile. So here's an example. If your patient has SLCO1B1 poor function, but they need a high intensity statin, we recommend you choose rosuvastatin over atorvastatin. Rosuvastatin would have lower risk of SAMs. The recommendations are similar if your patient has SLCO1B1 decreased function. If your patient has genetically determined ABCG2 poor function, that's the one where you would want to dose rosuvastatin more carefully or use a different statin. So this kind of makes sense. If you recall, the FDA label for rosuvastatin recommends to use lower doses of rosuvastatin in patients who identify as being Asian. So it's probably because the increased frequency of these ABCG2 genetic variants in patients with East Asian ancestry. It's also recommended if your patient has genetically determined CYP2C9 intermediate or poor function to dose fluvastatin more carefully or use a different statin. And the evidence was insufficient for any strong effects of genetic variants in these other genes on statins and SAMs risk. So here's my next review question. Genetic variants in which of the following genes significantly increase patients' blood levels of statins? So is it A, SLCO1B1, B, ABCG2, C, CYP2C9, D, all of the above, or E, none of the above? So who thinks A, B, C, D, or E? Oh, you guys are right. You are paying attention. Great. Okay, so that is my very high level summary of, what are the current pharmacogenetic recommendations for some of our most commonly prescribed cardiovascular drugs. Obviously, it's going to depend on every individual patient situation and their individual risk factors. But I do want to spend some time covering what are these major recent changes that are advancing the clinical use of pharmacogenetics. In my 15 years of my career in this field, there has been a lot of skepticism about, does pharmacogenetics really work? And if it does, how do we even implement this? So the first thing prescribers will tell me is well, there aren't prospective randomized controlled trials or RCTs showing that using pharmacogenetics significantly improves clinical outcomes for patients with cardiovascular disease. Sure, lots of evidence in cancer, but not so much in cardiovascular disease. Well, this isn't true anymore. There's now multiple randomized controlled trials and very large trials showing that when patients were randomized to genetic-guided cardiovascular drug therapy versus patients randomized to our current standard of care, which is non-genetic guided cardiovascular drug therapy, the patients who get that genetic-guided cardiovascular drug therapy, they either have significantly improved drug efficacy or significantly lower risk of adverse reactions to that drug. So here's some screenshots from some of these trials. I mean, they're published in the highest impact journals. I'm not going to go over any of these trials in detail, but they're published in New England Journal, JAMA, JACC. The one trial I did want to focus on today is called the PREPARE trial. So PREPARE was published in Lancet just last year. It was a 12-gene pharmacogenetic panel to prevent adverse drug reactions. It was open label, multi-center, controlled, cluster randomized, crossover implementation study. So this was the landmark trial that was published, and we in the pharmacogenetics field was well, finally, this proves what we had suspected all along. So PREPARE was performed by the UPGX consortium, or Ubiquitous Pharmacogenomics Consortium in Europe. So it was performed across the 7 European countries in red. Each white star was a coordinating site for the clinical trial. So this demonstrated not only efficacy of genetic-guided drug therapy, it also showed feasibility. They were able to accomplish implementation of pharmacogenetic testing across a wide variety of healthcare systems and settings. So the patients received this card when they enrolled in the study, and the QR code, you could scan it, and it says to the healthcare provider, please scan the QR code to view pharmacogenomics-based drug dosing recommendations for this patient. So you could scan the QR code to get their genetic test results, or you could flip to the back of the card, which gives a summary. So this patient example, Jane Doe, her first gene status is she's CYP2C19 poor metabolizer. So the critical drug substances where a modification is recommended includes clopidogrel and sertraline. So you can see lots of different medications were included in this trial. They did test 12 different genes, drug metabolizing enzymes and transporters. So they affect lots of different drugs. But I wanted to point out to this audience is because of the prevalence of cardiovascular disease, the most commonly prescribed and the index drugs in this trial, number 1 was atorvastatin, number 2 was clopidogrel, 4 was simvastatin, and in the top 20, we have warfarin, metoprolol, and acinocumarol. So this trial largely was proportionately cardiovascular drugs. So PREPARE enrolled nearly 7,000 patients randomized to either genotype-guided drug therapy or standard of care. There was a relatively short follow-up of just 12 weeks. The primary outcome was causal and clinically relevant adverse drug reactions. What does this mean? So they used 2 different previously validated tools to first establish causality of the adverse drug reaction. Was this symptom the patient reporting? How likely was it due to the drug, or is there another potential cause? So they only counted a possible, probable causal relationship for the adverse drug reaction to the actual drug. And then they assessed how clinically relevant is it. So they didn't count mild adverse drug reactions. So what they defined as clinically relevant was any adverse drug reaction that affected the patient's activities of daily living or prompted an interaction with the healthcare provider. So the event rate in the genotype-guided group was 21.5%. In the standard care group was 28.6%. This resulted in an odds ratio of 0.70, which was statistically significant, which means there was a 30% relative risk reduction of adverse drug reactions, a 7% absolute risk reduction of adverse drug reactions, which translates to a number needed to treat of 14. So we need to treat 14 patients with genetic guided drug therapy. We can prevent 1 clinically relevant adverse drug reaction. I mean, I think this is huge. I mean, we could prevent unnecessary morbidity and mortality in our patients. We could save healthcare providers time they don't have to manage adverse drug reactions for their patients. And it's also not surprising that the cost-effective analyses of this trial coming out after the trial show this is highly cost-effective too. And I'll talk about cost for pharmacogenetic testing later on. So this was a really striking statistic from the FDA. It says adverse drug reactions are the 4th leading cause of death in the United States. So I'm just going to repeat that for emphasis. The FDA says adverse drug reactions are the 4th leading cause of death in the United States. So this means that more of our patients are dying from adverse drug reactions than pulmonary disease, diabetes, AIDS, pneumonia, accidents, and automobile deaths. So, we were really excited about the results of this PREPARE trial, because now we have prospective randomized controlled trial evidence showing that using pharmacogenetics significantly reduces patients' risk of adverse drug reactions. So that's the randomized controlled trial evidence that was recent I wanted to discuss. So, next thing providers will tell me is like, oh, well, these tests are just too expensive. Our patients can't afford them. The cost of pharmacogenetic testing has declined rapidly in recent years, and it's actually equivalent to or less than a lot of other routinely ordered lab tests that we do in cardiology. So this cost is actually from our health system, our lab. So if you wanted to test a single pharmacogenetic gene, like say I just want to order CYP2D6 for metoprolol, that's $150 in our lab. If you wanted to order a multi-pharmacogenetic gene panel, so that's testing multiple different genes in a single test, that's what the PREPARE trial did, that cost ranges from $249 to $399. So how does this compare to other lab tests we already order for our patients? So for example, in our lab, an NT-Pro BNP or just a BNP is $203. Lipid panel is $126. So the cost of pharmacogenetic testing is pretty much equivalent to other tests we're already doing for our patients. What's really unique about genetic testing compared to these other lab tests, first is patient's DNA doesn't change. So you only need to order the pharmacogenetic test once in their lifetime. So like if they're a CYP2D6 poor metabolizer, their DNA code is never going to make a functional CYP2D6 enzyme in their life. Whereas, other lab tests we need to order serially to see how patients are responding and changing. And also genetic tests, because our DNA is the same our entire life, they can be performed before the patient starts the medication. So for example, we start a patient on a statin, they start complaining of muscle pain, so we order a CK level to see, is there actual muscle myopathy occurring? And so then you have to change statins, change doses, maybe hold the statin to make sure that myopathy or that CK elevation goes away. But with genetic testing, we could have done the genetic test before the patient starts the statin, try to select a statin with the lowest risk of SAMs based on that patient's genetic profile. Probably we could have prevented that myopathy in the first place. That is the ideal situation for pharmacogenetics. So a few $100s, that's not a trivial cost. A lot of our patients still can't or won't afford that cost of testing. So the next thing providers are concerned about is, well, pharmacogenetic tests, they're not covered by insurance. So we've seen really improved insurance coverage for pharmacogenetic testing in the past couple of years. So the health system in the United States that's been implementing pharmacogenetic testing for the longest is the University of Florida. So we were excited when they published their pharmacogenetic test reimbursement rate data last year. So this data is a year old now and it's changing rapidly. So on the y-axis is the reimbursement rate. On the x-axis is the type of pharmacogenetic test that was ordered, and they stratified it by therapeutic area. So cardiology is second from the left. So if a pharmacogenetic panel, they ordered it for 4 patients for a cardiology indication, 100% of those panel tests were reimbursed. There was lower reimbursement rates for single gene tests. So 275 CYP2C19 tests were ordered for cardiology indications. That's probably for Clopidogrel, only half are reimbursed. And 2 CYP2D6 tests were ordered for cardiology indications, and neither of those were reimbursed. So as I'll talk about later, now that Medicare covers pharmacogenetic tests with a CPIC guideline, and we just published that CPIC guideline for CYP2D6 a few months ago, since this data is a year old, now we would expect all CYP2D6 tests to be covered by Medicare. It was also interesting, the reimbursement rates were pretty similar regardless of the type of health insurance. So we might think, oh yes, fancy private insurance, that might cover something like pharmacogenetics. But actually they saw similar reimbursement rates regardless if patients had commercial, Medicaid, or Medicare insurance. So like I said, these reimbursement rates, they're expected to increase because the recent Medicare local coverage determination. So here's a screenshot from the CMS.gov website, so the Centers for Medicare and Medicaid Services, the Medicare coverage database. This is the local coverage determination for pharmacogenomics testing. So they revised this a year ago, and to summarize what it says, pharmacogenetic tests are now covered by Medicare if they have pharmacogenetic recommendations from CPIC or FDA. And we know usually what Medicare starts covering, other insurance companies usually follow. Specific to us in Michigan, your patients may also be eligible for no-cost pharmacogenetic testing through the Blue Care Network Personalized Medicine Program. So here's a screenshot of the information that's available online for this program. The URL's at the top of the screen. And so you could ask our pharmacogenomics specialty pharmacist, is my patient eligible for no-cost testing if your patient has Blue Care Network? So we see, insurance coverage is getting way better for pharmacogenetic testing, but some providers are like, well, my health system doesn't offer pharmacogenetic testing, so I'm not able to order it. Now there's improved availability of pharmacogenetic testing, lots of different ways that providers can order pharmacogenetic testing. So many more health systems in the US are now implementing pharmacogenetic testing. Also expect this to increase with the publication of that PREPARE trial. So when I was a fellow at Ohio State University and I led this study in 2017, there were 7 health systems in the US that were implementing pharmacogenetics, and we were studying how are they doing it, what are they doing, and we published that. Now in 2024, there's more than 50 health systems in the US are implementing pharmacogenetic testing. And the bottom right is a screenshot from the CPIC website, which lists these health systems that have said, we're implementing now. You can put us on the website and contacts at those health systems. So many more health systems are implementing. This includes us. If you're not aware of that, we have implemented a few pharmacogenetic tests for certain drugs and genes. And you may not also be aware, Michigan Medicine now has a pharmacogenetic specialty pharmacist service. So I wanted to introduce you to them. So that's Amy Pasternak. She works in inpatient. So if you've interacted with either of them, it's probably Amy. Also Kristen Ward. So their email is at the top of the slide. Their MyChart in-basket pool name is Pharmacy Pharmacogenetic Consult. If you have any pharmacogenetic questions, you'll notice I'm not pictured on this slide. So now that I'm working on the national level, writing these guidelines, I actually am not working on the operational level in our health system. I could try to answer any questions you may have about logistically, how are we doing this in our health system? But Amy and Kristen would be way better at answering that question for you. You might be wondering, why am I showing you Kristen Ward? She works in ambulatory psychiatry. We are here in the CVC. The reason I'm showing you Kristen is patients can get their pharmacogenetic test results from their other healthcare providers, for example, in psychiatry, that also apply to their cardiovascular drugs. So, one example of a pharmacogenetic test that's ordered in psychiatry to help patients find the most effective mental health medication without side effects. Here's a screenshot example of one of those tests. It's called GeneSight. So it's the same drug metabolizing enzymes that I covered in this presentation. So even though this panel was ordered to guide mental health medications, it includes results for CYP2D6, which I covered affects patients' response to metoprolol. It includes CYP2C19, which affects patients' response to Clopidogrel. So these genetic test results may already be in your patient's chart, and you may not know it. So if your health system doesn't offer pharmacogenetic testing, the National Library of Medicine has this publicly available genetic testing registry where you can look up labs that offer any kind of genetic tests you may be interested in ordering. So here's a screenshot of when I searched for a genetic test for metoprolol, and metoprolol response auto-populated. And here's the results. So there's 8 human genetic tests for metoprolol response from 5 different laboratories. And they list the labs and some information about the genetic test. So you could order these genetic tests. Our Michigan Medicine pharmacogenetic pharmacists tell me that if you're interested in ordering any new genetic test, ask them if these tests are already integrated in our system. They may be, or if not, how they can integrate them into our EHR. So that's many different ways providers can order tests for their patients. So here's my next question for you. True or false? Patients can order pharmacogenetic tests themselves. So who thinks this is true? Raise of hands. A few. Who thinks false? Actually, I think there's more trues and some abstains. This is true. This is true. The FDA approved the genetic results from 23andMe, the direct-to-consumer genetic test, for pharmacogenetics. It includes 33 variants and 8 genes, including the genes I covered earlier that affect cardiovascular medications. So over 10 million people have bought 23andMe, including, they get interesting ancestry, family information, but it also includes some health information, and it includes pharmacogenetics. So for under $200, any patient can send a saliva sample in the mail, get their full genome results, and they can get a pharmacogenetic report too. And this is FDA approved. The 23andMe genetic test is done in a CLIA approved lab. Most of these results, if a patient were to come to you and say, oh, I got this pharmacogenetic result from my 23andMe, I got it as a Christmas present, what does this mean for my medications? Most of the time, you would have to order confirmatory clinical testing, except for the FDA says an exception is clopidogrel and citalopram. So the FDA says the 23andMe direct-to-consumer results for clopidogrel and citalopram are just as good as any clinical tests that you could order, and thus they can be used in clinical medical decision-making. So this was a interesting new development. So another concern about providers, well, there's no place for pharmacogenetics in the EHR. Now there's many different software companies, including Epic, that have found ways to integrate pharmacogenetics in the EHR and clinical decision support. So here's a screenshot from my chart. If you search genomic, it could jump to genomic indicators. So this is where passively genetic information is stored. So on the top, there's, does this patient have genetic variants causing a particular disease like familial hypercholesterolemia? Or does the patient have genetic test results affecting any drugs? So this patient happens to be a CYP2C19 normal metabolizer. There's also active BPAs. One that we have implemented in our health system is for clopidogrel, but it's only for if a patient meets a certain narrow set of criteria. So it has to be a patient, they have to be CYP2C19 intermediate or poor metabolizer. We have to know that result already in the EHR at the time of PCI order entry. And so you may have seen this yellow pharmacogenomic warning if your patient meets these certain criteria. So we don't have broad, widespread pharmacogenomic warning for like any patient prescribed clopidogrel, but only patients with this in this certain situation in our health system. So another thing that providers will tell me, well, pharmacogenomics is still just not recognized as the standard of care. There is really increased public patient awareness of pharmacogenetics. There have been 2 lawsuits that made major headlines recently that have drawn attention to this issue. So the first is, it says OHSU to pay $1 million, promises change to settle lawsuit from widow of cancer patient. So this man, David McIntyre, he had cancer and he was being treated with chemotherapy at Oregon Health and Science University. So there is an adverse reaction to the type of chemotherapy he was receiving that is very severe, could be fatal. He did have that adverse reaction to his chemotherapy and he died from it. But there is a pharmacogenetic test for genetic variants where you could identify patients who have increased risk for this adverse reaction from this chemotherapy. Oregon Health and Science University did not do that pharmacogenetic test, and he died. And so this was a really terrible story. This man, he didn't die from cancer. He died from an adverse reaction to his cancer therapy, and it could have been prevented with a pharmacogenetic test. So this is, we're in the CVC, so of course, they should have been doing genetic testing in cancer, right? Well, there was another recent lawsuit that made headlines to bring attention to pharmacogenetics for cardiovascular drugs too. So this headline says, Bristol Myers Sanofi ordered to pay Hawaii $834 million over Plavix warning label. So Plavix is the brand name for clopidogrel, and those genetic variants that decrease CYP2C19 function, they are very common in patients who have East Asian and Oceanian ancestry. And since the majority of the citizens in the population of the state of Hawaii have East Asian or Oceanian ancestry, the state attorney general of Hawaii sued the company that makes Plavix saying, you know about this pharmacogenetic effect and you're selling an ineffective drug to the majority of the citizens of the state of Hawaii, and the state of Hawaii won. And so the company has to pay millions of dollars to the state of Hawaii. For many people, Hawaiians who died taking clopidogrel or had heart attacks or strokes because they had these genetic variants in CYP2C19. So there's increased public patient awareness of the importance of pharmacogenetics. So another thing that providers say is like, well, there's just no clinical practice guidelines for pharmacogenetics of cardiovascular drugs. So admittedly, AHA, like we have lagged behind in getting these recommendations into the guidelines. We published it in several statements, but slow to change guidelines. But that's why I'm here today. We now have pharmacogenetic recommendations from CPIC, FDA, AHA. So I'm glad for the opportunity to talk to you all today. So here's my last review question. Which of the following major recent changes have facilitated the clinical use of pharmacogenetics? A, do we have prospective randomized controlled trial evidence showing pharmacogenetics significantly improves patient outcomes? B, we now have low cost for pharmacogenetic testing. C, we now have improved insurance coverage for pharmacogenetic testing. And D, there's improved availability of pharmacogenetic testing. Or E, all of the above. So who thinks A, B, C, D, E? All right, awesome. Yeah, so many of the previous barriers that there was to the use of the clinical use of pharmacogenetics, I feel like we have overcome all of those barriers now. I think the last major remaining barrier is just clinician awareness. So that's why I'm glad I could talk to you all today. So that's what I was going to cover today. Just to summarize the main points, pharmacogenetics is the field of research and clinical practice that assesses how patients' genetics influence their responses to drugs. Patients have genetic variants that decrease their ability to metabolize some of the most commonly prescribed cardiovascular medications. And the three examples I covered today are metoprolol, clopidogrel, and statins. And many major recent changes have greatly facilitated the clinical use of pharmacogenetics. I mean, the main ones are probably Medicare coverage for pharmacogenetic testing, the PREPARE trial, EHR integration. Many of these barriers have been overcome. So to summarize the recent clinical recommendations, first is metoprolol should be dosed more carefully in patients that have genetically determined poor CYP2D6 metabolism. Clopidogrel should be avoided in patients that have genetically determined intermediate or poor CYP2C19 metabolism. Statins with the lowest risk of SAMs, which is statin-associated muscle symptoms, should be selected in patients with genetically determined decreased or poor SLCL1B1, ABCG2, or CYP2C9 function. So here's my plug for our recent genetic certification course. With the AHA, I taught the pharmacogenomics section. So if you'd like to learn more about how you can integrate genetics into your clinical practice, I recommend you check out this course. And I'd like to thank the many organizations that I work with and the University of Michigan College of Pharmacy for supporting me in this work that I do at the national level. My lab, my mentor, David Lanphier at Henry Ford Health, and of course, my funding from NIH. And thank you all for your attention, and I'm happy to take questions.
There we go. Okay. Two quick questions. You said that you don't need to repeat these tests because a person's genes don't change. My question is, has the knowledge changed? So as an example, if a patient had gene site testing 8 years ago, in the last, that seems like 1 million years in genetics research. Is it worth repeating something like that now because you pick up more knowledge than you would back then? That's the first question.
Yes, that is a good point. So the pharmacogenetic evidence is rapidly evolving. We are learning about more and more and discovering more genetic variants that can affect different medications. Like my own lab, we've discovered some new genetic variants using our own biobank here at the University of Michigan that we hope will eventually get into guidelines and statements. So yes, that is true. The knowledge of, which genetic variants can affect drug response do change over time. So as far as the pharmacogenetic tests that I covered today, There's a website called PharmD. It's the Pharmacogene Variation Consortium, and they every time a new variant is discovered that affects drug response, they upload it, rate it, link it to the evidence. So that stays up to date. But yes, the genetic test results may not. So it could be worth, depending on which drug you're interested in, if new genetic variants have been discovered from an old test, yes. I mean, it would be worth retesting. But if the patient has like a loss of function, CYP2D6 variant 10 years ago, I mean, I think it's highly unlikely we'll find it's encoding an enzyme that's missing, multiple amino acids. So I think it'd be unlikely to find a genetic variant that activates CYP2D6 activity. So I think some of the genetic test results may not change over time, especially for those loss of function variants. But yeah, as more knowledge is discovered, I think it would be useful to update pharmacogenetic test results. What was it, your second question, or?
Yeah, the issue is, to me, listening to this, I should just avoid using metoprolol, there's other beta blockers, and I should just avoid using Clopidogrel, there's a couple other, and not worry about testing these.
Yeah,
It
would make it easier, right? I mean, we still like to have options. I mean, bisoprolol is very similar to metoprolol, could be an equally equivalent alternative. It's beta-1 selective, once daily dosing. It's also generic. So yeah, I mean, that might be a case where there's an equally effective alternative where if you just don't want to worry about the genetic testing for metoprolol, metoprolol is still the #1 most prescribed beta blocker in the country. So there's just historical precedent for choosing certain drugs within a class. I forget what was the other. Oh, you said Clopidogrel. Yeah, I mean, the Clopidogrel evidence, it's mostly supported for de-escalation instead of escalation. So, across the board, usually it's ticagrelor or prasugrel. If you get this genetic test, and the patient is normal or ultra rapid metabolizer, then Clopidogrel, a big trial, the popular genetics trial showed Clopidogrel is equally effective but lower risk of bleeding. So that might be one case where, yes, you could maybe lower patients' risk of bleeding and have equal efficacy with Clopidogrel. Also, there's other reasons why you wouldn't use ticagrelor or prasugrel. Prasugrel has certain contraindications that Clopidogrel doesn't. So the hope is in the future, everybody's whole genome will just be in the EHR, and we'll just have this information already. We won't have to worry about making the decision of do we order the test or not. It's already in the EHR. So that's the ideal scenario in the future. Like our genomics is just a normal part of our EHR. But yeah, now we're in a tricky time of like, is the evidence strong enough to order this test, So yeah, it's very clinician dependent. Did you have a question, Dr. Pinsky?
First of all, that was just superb, really helpful to us. So inpatient versus outpatient, I know for other genetic testing, we wait till we send people home because the price is actually lower. Is there a difference? So that's the first question. And then how rapidly can these tests be processed? So for instance, I'm planning a PCI for the next morning, say I have a positive stress test. Can I get the result immediately to guide my dual antiplatelet therapy?
Yes, good question. So there has been rapid point of care. Genetic testing could give you a result within an hour or two, which cath labs have used for making antiplatelet decisions. I heard recently that test was pulled from the market, but I've heard there's more companies trying to develop a replacement for rapid point of care testing. In the absence of that rapid point of care testing, an example is the PREPARE trial. They were able to get the results in a range of between 1 to 7 days. So that's like the typical turnaround time now. As far as reimbursement, yes, it's very different whether you're trying to bill for that pharmacogenetic test inpatient or outpatient. What I've heard that health systems are doing for inpatient is because the cost is actually not that high, they're rolling it into DRG billing, and then outpatient, I think it's probably covered by either this new Medicare determination or the private insurance companies like Blue Care Network that are just trying to do these panels in patients. So that information is already available too.
I have a quick question.
Yeah.
So first of all, excellent talk, very informative. My question is a little bit related to how do we translate this into the real world clinical practice? And do you think that large healthcare systems should test genetically for a panel, let's say, of medications, cardiovascular medications? Should we wait for side effects to develop and then test and assess our medication change? And then the other thing is, how do we support the clinicians? This is another layer of complexity to what is already a very complex field.
Mhm.
So I don't know if you have any thoughts about that.
Okay, so the first part of the question is, should we, like, who should we test and how should we test? Should we do panel? So what the evidence is showing from these health systems that are implementing is saying the most efficient and most cost-effective, like I showed the University of Florida data, 100% of panels are reimbursed by insurances. So you're going to get better reimbursement if you're testing for a panel as opposed to a single gene. Like, okay, I'm starting my patient on metoprolol, let me just test for CYP2D6. Also, what's most effective, based on what Dr. Pinsky said about the turnaround time, is to have preemptive tests. So have it done, have it already in the EHR. So when you do need it, when you prescribe that medication, then that information's already there. You don't have to wait for sending the test to the lab, getting the results, getting it integrated into the EHR. So I think, the best way to do it is a preemptive panel. And it's been interesting to see, when we studied the health systems that were doing pharmacogenetics, like they all did it different ways. Like who could order the testing? Who was part of the workflow? Like, do we involve genetic counselors? Did the pharmacist return the results? Like every health system did it differently. The only common thread among health systems that are doing this is they're prioritizing CPIC guidelines. That was like the one thing they had in common. As far as like supporting clinicians in this, also have seen different things, like lots of education like this, in-person education. Sanford Health System, which is in the Dakotas, is really interesting. They test every single patient in their health system for a panel. They required pharmacogenetic education for all healthcare providers. I heard they tied it to their pay, like their salary. If they didn't complete this pharmacogenetic test education, they didn't get their paycheck. I guess is it Denny Sanford was a very strong advocate for pharmacogenomics. So that's why Sanford Health is very unique, and every single patient gets a pharmacogenetic panel. They have like an army of pharmacists to help do that. Some health systems, all they've done is just send out the clinical decision support. Like they don't have in-person education, like going in detail. How are we doing this? I mean, conceptually, it's very similar to how we get drug-drug interaction BPAs in the EHR. If a patient is a CYP2D6 poor metabolizer, it's like they're being treated with a strong CYP2D6 inhibitor. So it's not too different from what we already do to try to optimize patient medication. So sometimes, yeah, it's just pushing out new clinical decision support, or there's a lot of in-person education.
I have one
And
question.
we have the pharmacogenetics pharmacist specialist service here to help support you. I think Murthy had a hand raised.
Okay. Venk, I don't know if you want to ask a question.
Yeah, hi. Really wonderful talk. Thank you for all that information.
We can hear you, Venk.
Can you hear me now?
No.
Okay.
Do you want to type it and I can? Oh, we can hear it from here then. Sorry, Venk. It seems like you can be heard in Zoom, but we cannot hear you here in the audience.
The chat?
Yeah.
Okay, wait. Open the chat.
So in the meantime, I have another question from Dr. Eagle. He says, fabulous talk. How close are we to automatic EHR alerts for our patients with 3 key areas you covered, metoprolol, clopidogrel, and statins?
Like I said, we do have that narrow implementation for Clopidogrel if they meet certain criteria. As far as I know, we don't have any plans in the immediate future to start implementing these tests for metoprolol or statins. I mean, that the CPIC guideline we just published a few months ago. The statin guidelines, I think, a year old. So yeah, I know our pharmacogenetic pharmacists are slowly trying to implement and add more and more, like, what are the pharmacogenetic tests we're doing here? It's really difficult. There's a lot of different things to consider, you know, which lab should we order the test? How do we get the test results in the EHR? Because multiple different labs are doing these tests. I guess it's very difficult to integrate them with our EHR. We have to investigate insurance coverage and so many different insurance options for our patients. So yeah, I mean, I could discuss it with Amy and Kristen and see, like, you know, what are their plans? What are the next pharmacogenetic tests that are in their queue to start implementing? But as far as I know, these cardiology ones are not prioritized yet.
I have one last question from Vink Murthy. Wonderful talk. Is there evidence people are likely to be underdosed by using this information? Meaning, if people are told that a given patient is sensitive to metoprolol, do they end up at higher heart rate at the end of their titration?
Yeah, it's a good question. That is a concern. But so dose is different than what we're talking about blood levels. So, so even though patients who are poor CYP2D6 metabolizers, they may be sensitive to lower doses of metabolizers or lower doses of metoprolol. Even on lower doses, they have way higher blood levels at the same dose. So we would still expect the same effect even at lower dose metoprolol. So good question. Did you have a question?
Yeah, that was a great talk. You said statins, Clopidogrel, and metoprolol. Those are common, especially in all patients that come in with an MI. I mean, is there a consideration for essentially making it mandatory for everyone that comes in with an MI? Granted, it may take some time to come back, but then with 30-day mortalities and being very, how should you see that?
I don't. As far as I don't think any health system is making it mandatory. Like even Sanford, where they've tested all the patients and they educated all the healthcare providers, I don't think they make it mandatory to change the medication based on the patient's genetic test result. I mean, there's so many different individual factors to consider with every patient. Like maybe there's a really good reason why they can't go on an alternative medication. So I wouldn't do like a blanket mandatory recommendation.
And Ted, last question.
It is a great talk. And just following up on the other questions that were asked, has there been any modeling of looking at just as every patient comes into the health system, just getting this panel? Because, you know, we talk about just the statin alone, it's the most prescribed drug, and it would really guide which one to use, and it would reduce side effects just from that alone. It seems to me the benefits just from a cost analysis would be helpful, not to mention, you know, from a health analysis. So has that been looked at?
Yeah, I mean, so like I said, the PREPARE trial, atorvastatin, simvastatin, they were like the top 5 drugs used that we could help prevent adverse drug reactions for statins. And I think the best data from the United States was a study from the VA. I think they started the Million Veterans Program. I think they've done pharmacogenetic testing in hundreds of thousands of VA patients. And when you look at the panel results, I think it's 99% of patients have some genetic variant in any of those drug metabolizing enzymes or transporters. So all of us, we have a genetic variant that's going to affect medications. Then the question is, well, how likely is it, are they prescribed that medication that, you know, is a match for their genetic variant, high risk genetic variant? And I think it was about 25% of patients. So yeah, so we could, I mean, it would apply to lots of patients. So we're talking about very commonly used medications, and these aren't rare genetic mutations. They are quite frequent in the population.
Thank you so much.
Sure, thank you all.